So Dr. Carlson is the chief, or actually just stepped down, is the chief of the Division of General Pediatric and Adolescent Medicine at Floating Hospital for Children. She's a general pediatrician and has her clinic there. She got her MD at Tufts University and then did her internship and residency at Floating Hospital for Children, which was New England Hospital back then, and also Baylor College of Medicine. And she's currently an associate professor of pediatrics at Tufts University School of Medicine. We're very excited to have her. She has received the top doctor honor from Boston Magazine very many times, 2012, 2013, 2015, and 2017. She has not reported any relevant ECG-defined conflicts of interest. So I'd like to introduce Dr. Carlson.
Yeah, top doctors. There's a lot of us. Okay, so pediatric obesity, a problem we see all of us every day in our practices. Okay, we're going to talk today about the magnitude and etiology of the problem, and what we can do as pediatricians to help in terms of prevention and also treatment of obesity. Oh, there's a blank slide. What happened? We all know overweight is 85th to 95th percentile, and obesity is defined as a BMI greater than the 95th percentile. The actual numbers for BMI that are used in adults aren't relevant in children. That's why we need to look on the growth charts to check the percentile. The problem has been increasing greatly. This is the latest Nahain study. This is a study that's done nationwide every 4 years. The last data we have is from the 2014. We should be getting some new data this year. And you can see the problem has been increasing pretty steadily. But do you notice one piece of good news? The 2 to 5-year-old has been leveling off in the last few years. And that's probably partly because of us and what we do as pediatricians in giving more and more guidance about food to our patients. And also the WIC program has gotten on board and now doesn't give juice to babies under 2, which has been a huge win for us, I think. And we often are moving to low-fat milk a little bit sooner than we used to. So we may be having an impact. And this, one hopes, will translate into some improvement at older levels, older ages, a little bit sooner. Okay, we care about obesity because there are a number of medical complications, some of which are in Dr. Sadeghi's wheelhouse. Type 2 diabetes is primarily not a pediatric problem, but there are more and more teenagers being diagnosed with type 2 diabetes, and certainly with, quote, pre-diabetes, abnormal fasting glucose is slightly elevated A1Cs. So it's something that we are beginning to monitor for at a younger age than one might expect. Hypertension, dyslipidemias, hyperinsulinemia, metabolic syndrome, sleeping problems, snoring, and apnea. It makes asthma worse. I wouldn't say obesity causes asthma, but it certainly can make it worse because of pressure and also lack of activity. Degenerative changes in the joints, especially the lower extremities. Skiffy, which we see in those chubby prepubertal, mostly boys. GERD, non-alcoholic fatty liver disease, which many of our obese kids have, although we don't check for it on a routine basis, most of us. And gallstones, all are associated with obesity, even in childhood. We've all seen this in the office. Eric, what's that? Right, acanthosis nigricans, okay. And we see it in black kids and white kids. If parents have been trying to scrub it off sometimes, they want to know what kind of rash that is. And it gives you an opportunity to really address the issue of obesity in those kids. It's a symptom of hyperinsulinism, I always discuss pre-diabetes and the possibility of diabetes in the future in kids who have this. So it sometimes serves as ammunition to make some of the changes that we'll be talking about soon. This is striae from rapid weight gain. We see this in pregnant women, of course, but also in kids who've grown very quickly or have gained a lot of weight. And we know, because I know Eric's here. This is some hip films, frog lateral. What do you see on the red arrow? Slip capital femoral epiphysis. There's the ice cream slipping off the cone. Okay, this is something you don't want to see, but it's highly correlated with overweight and obesity in prepubertal kids. There are also psychosocial complications of obesity that are sometimes more significant than we would expect. There's a social stigma from other children and from adults. From other children, it tends to get worse around middle school, but can start much earlier, which then leads to school avoidance, depression and anxiety, because the kids are isolated. They get poor self-esteem, and there's a relationship between increased drug and alcohol use later. There are quality of life measures have been used. There's a researcher at Tufts who's doing quality of life measures in a number of different groups. And the quality of life scores for kids who are obese are lower than the scores for kids with cancer. So it can have a very dramatic effect on quality of life. People don't get blamed for cancer, but they do get blamed for obesity, and that's one of the issues that we'll talk about a little more. So obese children tend to become obese adults with the subsequent long-term complications. If you're an obese preschooler, you have a 32% chance of becoming an obese adult. If you're a school-age child, it's 50%, and if you're an obese adolescent, you have an 80% chance of maintaining that problem through adulthood. So we'd like to get rid of it sooner. Okay. And on adult health, we know that there's increased rates of mortality of all causes for obese patients, and especially coronary artery disease in both men and women. In fact, if obesity starts in childhood, it may be a greater predictor of some of these long-term effects, just because it's been there longer. There's more years of exposure to this toxic internal environment. So why are we dealing with this? Why is this happening? There are many, many levels at which obesity is a problem for us. In the orange there, I have a little pointer, but it's probably not necessary. We talk mostly about the families and the individuals. What's happening at home? What are the parents' beliefs? The children's attitudes and beliefs and exposures. But it's much broader than that. The yellow circle is the next level of behavior. The settings the kids in school, maybe they only have chocolate milk, or the school lunch isn't healthy. I mean, the point of this slide is that there are many, many levels all the way up to policy and advocacy area that contribute to the obesity epidemic, and blaming the patient or the family specifically is not helpful. There's much more that we can do to help as advocates, pediatric advocates, for changes in policy, in the green circle there, the food systems and built environment, making parks, making bike lanes. We can advocate with our cities and towns and the state to improve the environment that our kids are living in, so that they can be more active and have better choices in terms of food and nutrition. There are people always ask about, well, what about other causes that aren't, what we all talk about, eating too much and not exercising enough? There are some medical etiologies. These are not common, but as we're often asked about them, I have a long list. Again, many of which are in the endocrine area. Hypothyroidism is one possible cause of obesity, and almost every patient that comes to our obesity clinic has either already been tested for thyroid, or the mother says it's probably their thyroid. Can you test for the thyroid? And you know what? We haven't found one yet. Because there are other symptoms of hypothyroidism that the pediatrician has usually figured out before they come to us and has treated, because this is a treatable condition. There are other endocrine tumors that can lead to obesity. Again, children have other symptoms, usually signs of increased intracranial pressure. Hypercortisolism. Again, there are other symptoms associated with that, including this distribution of fat that's unusual and increased striae. These are things that can be figured out by endocrine testing. Hyperinsulinism and hypothalamic issues can lead to obesity, again, all quite rare. There are genetic syndromes that are associated with obesity. The one that we know the most about is Prader-Willi. And again, there are other signs. Those kids are hypotonic, and poor feeders usually have failure to thrive in the first 3 months due to the hypotonia. But it is the most common syndromal cause of obesity. And you can see what its frequency is, 1 in 25,000. It's not very, very frequent. But these kids need much more treatment than just treatment for their obesity. They have developmental issues and behavioral issues. There are leptin deficiency. People say, we read a lot about leptin because there's a lot of research going on in the area. There have been 20 cases described in the literature, so it's unlikely that you're going to run into this. But it does give one hope that there may be other specific causes discovered over the next 20 years as people are looking so hard. And maybe there will be other methods of treating obesity, which we all know is a very frustrating thing to try to do. These are other genetic discoveries that have been made over the last few years. Again, very rare. The MC4R gene, that isn't a rare problem, but most of the time it doesn't actually lead to obesity. But it is one of the genes that's associated with some types of obesity. And epigenetics, we talk about. The main epigenetic influence that we know of is obesity of the mother during pregnancy, and that can have an influence on the infant and the likelihood of that child developing obesity later. So there is another differential diagnosis that we think about, not necessarily those weird genetic syndromes, but depression can lead to overeating. It's a type of self-medication. It's been said that food is the most overused anti-anxiety medication that we have. And exercise is the least used antidepressant that we have. So those are things to think about with all your depressed and anxious kids. Again, hypothyroidism and insulinoma, Kallmann syndrome, it's a CNS problem with, remember, anosmia. Generalized lipodystrophy, which has very distinct physical findings. PCOS is associated with obesity. It probably isn't a cause of obesity, but they run together. Cushing syndrome, acromegaly, and we list ascites and anasarca. That's not obesity, and hopefully one would recognize the difference, but they certainly lead to a high weight and can sometimes be confused with obesity because the weight is so high, and you don't, if you're not looking for other things, doing a good physical, for example, you might not notice that. Okay, so most obesity, what we see is over 90% of it is exogenous, which has to do with the whole environment that we've been discussing. Endogenous obesity is much less common, less than 10% of cases, and there are some differences that can help us to distinguish and decide who needs further testing. Exogenous obesity, kids who overeat also tend to be taller than average, so they're high on the growth chart, not just for weight, but also for height, although usually the weight is higher than the height. Endogenous obesity, because it's often related to hormone problems, the kids are often short. Most exogenous obesity, there's a positive family history, less so with endogenous. And the exogenous obesity, most obese kids are perfectly normally functioning in terms of their development. A lot of the genetic syndromes that lead to endogenous obesity are associated with intellectual impairment. And the bone age in obese kids can be advanced. It's often delayed in the kids who have hormone problems. And they have a normal physical, except for the obesity, and possibly some high blood pressure, which isn't really normal. But and there are often other stigmata in kids who have a syndromic type of endogenous obesity. So those are things to watch for. When you see an obese kid, you have to at least think about these other issues. Okay, there are a number of factors that contribute: race and ethnicity, Hispanics and blacks have a higher incidence of obesity. Socioeconomic status and food insecurity are important factors. There are kids who are poor are not always thin just because they don't have good food. In fact, because the food that they get is high in calories and cheap, they are often overweight or obese, but they are malnourished in terms of their micronutrients. So it's important to take that into consideration. The WIC program and food stamps, of course, are very helpful in getting our patients a diversity of food if they know how to choose it. And that's one of the ways in which we can be helpful. Okay, parental education and income are associated with obesity, and medication. Now, classically, steroids are the ones that we've thought of, but lately there's a whole other category, the atypical antipsychotics. If you have any kids on the atypical antipsychotics, they are like risperidone. I mean, they all really, almost all of them gain weight and very often get some symptoms of metabolic syndrome. The AAP is now recommending routine testing of those kids on a yearly basis for hemoglobin A1C and glucose because of the long-term effects of those medications. So other factors that are modifiable in a way are the environmental factors. Okay, things that we talk to families about in our clinic and in our practices is the toxic environment. The food portions have become much greater over the last 20 years. I would refer you to a Google portion distortion, and there's all kinds of quizzes and information about how portion size and the perception of what's a normal portion has changed over the last 20 years. A bagel 20 years ago was 3 inches in diameter and had 150 calories. A bagel now is 6 inches in diameter and has 350 calories. And people think that they're both one serving. And so our expectation of how much food one should eat has changed tremendously. And that in and of itself can be an area where we can really educate our patients about what's a normal portion size. Fist size, the size of the child. Not your fist, the baby's fist or the 2-year-old's fist. Can be helpful in saying this is how much you should eat. There's less physical activity and increased sedentary activity. Those are similar. They're strongly related, but they're not exactly the same. So it's just sitting, watching television, or doing screens. I mean, we all see that even in the office you have toddlers on their parents' phones, right? It makes us crazy. Okay. Those things both lead to less need for calories. The sleeping less, again, for teenagers at least, the phones are part of the culprit here of reduced sleep. And there's increased stress in the environment. For a number of reasons, some political, some having to do with the constant media cycle, that you just can't escape from always being bombarded with news, good, bad, or different. It causes stress. And of course, kids are stressed about school very often. Those things all lead to increases in obesity. So what can we do? There's the 5 A's of obesity counseling, which we're going to talk about a couple of times here. First, we do an assessment. That's something we do as pediatricians, hopefully starting when they're very small. How much did the mom gain when she was pregnant? What was the birth weight? Following the growth curve, finding out about feeding practices in the family. Then we answer parents' concerns. We give them appropriate education about obesity if this is an issue. Agreeing, which this gets into the what we're going to talk about later, and then assisting them to address the barriers and arrange frequent follow-up. Frequent follow-up is key in a pediatrician having real impact on the treatment of obesity. So when we do an assessment, we talk about how many times a day they eat, eating together as a family, very important, not only for weight control, but also in terms of the development of kids. We know that there's less delinquency, in kids, school age, and adolescents who actually eat meals with their family. It also role models good eating behaviors, assuming the parents have them, and it increases the variety of foods that the kids are willing to try. Limit eating out. Eating out, you tend to overeat, and again, that portion issue is huge on eating out. You tend to be higher fat, calorically dense foods when you go out to restaurants, especially fast food restaurants, but really any restaurant. Eliminate sugar-sweetened beverages. So no soda, almost no juice. Those are that's the low-hanging fruit. That's the easiest advice to give, and very often people are willing to go along with that because it's pretty simple. 5 fruits or vegetables per day. That seems like a lot of vegetables to a kid, but fruits count, and vegetables in soup, salads. I mean, there are lots of ways to sneak vegetables in. Limiting chips and crackers, limiting candy, sweets, getting at least 9 hours of sleep, less than 2 hours of screen time, and that is tough now because screens don't just mean television. And greater than 60 minutes of activity. Those are the goals that we aim for. And so in your assessment, you talk to families about all of these issues. Okay. So as a PCP, we talked about the history. Okay. So you can try to identify children who are at risk to start. Again, we talked about overweight families or obese mothers during pregnancy, and birth weight is important. Actually, both SGA and LGA babies are at increased risk of obesity. And the reasons for that aren't entirely clear. The LGA is considered to be an epigenetic phenomenon, and that may also be true of the SGA babies, but I think a lot of those small babies, we train the parents to feed them all the time because they're little to start, and they get in this pattern of I always have to be trying to get my baby to gain weight. And we have to be careful that way when we're reviewing the growth charts with the families. And early childhood feeding practices are important, and we have to deal with this really in the nursery or prenatally even, is trying to encourage breastfeeding as much as possible. And when we introduce solids, you can start with we always have started with cereal, but you know what? You can start with vegetables. It doesn't have to be a higher caloric density food. And again, teaching about portions early. Okay, and addressing the role of food insecurity. Making sure our patients apply for WIC if they need it, have access to food stamps if they are entitled to that, and sometimes a social worker can be helpful in your practice if you have a number of patients with these issues. Okay, and stress in the family. Sometimes the stress is around food, but often it's about other things like money, school. So doing that assessment. And we also monitor growth. We look at the growth chart every time, show it to the family, especially if there's some problems, and we'll get you a picture of some growth charts in a second. You plot the BMI. Nowadays, if we all have ECW, it's plotted for you. You just have to open the chart. And that's true of most electronic health records now, is that you automatically get a BMI plotted with a percentile in your chart. And you provide positive reinforcement if it's normal. Isn't this great? They're right on the 30th percentile for height and weight. No, they're not too skinny. The height and weight are the same. That can be an issue. Okay, and then you address it if it's not in a healthy range. Okay, so being overweight at one time in childhood again greatly increases your likelihood of being then an obese adolescent and obese adult. So you've all seen growth charts. They don't always look this pretty in our charts, but anything in the yellow is overweight. And anything in the red is of great significance. And one of the things we really look for is line hopping. Okay, so if a child is hopping over lines, this is after 15 months, because in that first 15 months they have to channel and find the curve that they're going to follow. But after that, if they start going in an upward direction on the growth chart, it's something that should be addressed even before they get to the 85th percentile. So what is leading to this increased weight gain? And it might be juice, it might be an extra cookie a day leads to 10 pounds a year. I mean, it's quite significant. Even a small amount every day can lead to excess weight gain over a long period of time. So line hopping is something to really watch for. Okay. So we also screen for unhealthy eating behaviors. The Clean the Plate Club is out. We all know this, right? You try to put a healthy variety of food in front of the child in reasonable quantities, and they decide how much of it they eat. So parent provides, child decides. If the kid's full, they're full. And when the toddler starts throwing their food on the floor, they're done. You don't have to make them finish that last bite of chicken or that last 2 ounces of milk. They're done, and that's okay. Which is different from the way it was 30 years ago, when probably most of us were kids and we had to clean the plate because of the starving children in some other country. Right? Going to send it there. Okay. Again, in assessing and advising, I think every time you have a kid who has a weight issue, you at least have to ask about what are you drinking? What is it that, what kind of milk are you drinking? What else do you drink? And because this is easy. Okay, soda and juice are basically sugar and water. Even they'll tell you, with orange juice, it has a little potassium and some fiber and vitamin C, but you'd be better off eating the orange than drinking the orange juice. It's a right size for one thing, and it has more fiber and other benefits that the actual juice doesn't have. So limiting juice is to 4 ounces or less a day, and it's totally abandoning soda, except for a birthday party. I mean, you can't say to parents, you can never have this again. You can never have a piece of birthday cake. But it should not be it should not be in their refrigerator on a regular basis. Okay? So they can drink water. We all drink water. Okay, motivational interviewing is the process that was originally developed for helping people to quit smoking. Okay, but many of its attributes are useful in counseling families about obesity, especially teenagers, because they're actually if you can get them motivated. But it can also be used with families of younger children, and it's a collaborative way of working together with the family to figure out how can we make progress here. You're supposed to empathize, build rapport, and listen to the family about what they think they can do to improve things. Set a specific agenda, and then assess whether that patient or family is ready to make this change and how confident they are that they can make this change. You want to empower them, and the only way to do that is to have them have some input on. You can give advice, but they need to pick what's reasonable for that family. So this is usual practice versus motivational interviewing, but we think of going in and telling people what to do, right? And we tell them what's important. We decide what the goals are, and we prescribe the medicine, and hopefully everything works. Okay, motivational interviewing is helping the patient to set the agenda and collaborating and acting more as a coach for the child and family rather than as more of a top-down director. So those 5 A's I said we'd come to again. This is a way of breaking them up in terms of time. Now this adds up to 15 minutes, which may be all you have for your whole physical, which can be hard to do this in a regular visit, but you can begin to address it at the physical, and then in follow-up use this method of doing further assessment and giving advice and getting them to agree and assist is the motivational interviewing piece, and then arrange the follow-up. Because it's recommended that pediatricians see such children every 4 to 6 weeks. So these are examples of techniques, motivational interviewing sentences that one can use. And so you say, your child's weight is a bit higher than when I saw you last. Does that concern you? Well, if they say no, what do? Then you have to switch a little away from the motivation and say, well, let me tell you why it concerns me. This is the information giving part, which is what makes this different from the non-smoking. Everyone knows they shouldn't be smoking. But very often, especially with little kids, 2, 3-year-olds, you're telling the kid's overweight, and they see a cute little chubby toddler. We know it's not good in the long run, but the family, especially the grandparents, want this little fat kid. They think that's how they should look. Okay, so that's where the growth charts can be really helpful. And then once you get to to why it's at least of concern, what do you think might be leading to this? Do you have any ideas about? Yeah, did you have a question? Oh, okay. Are there any particular behaviors? And if they can't think of anything, then you got to start going into a somewhat detailed dietary history, because you may be able to identify them. And then when you figure that out, would you like to discuss working on one of these? This presupposes a fair amount of motivation, but sometimes we have to help with children in getting the family to be motivated, and that does make this a little bit different from dealing with adults. So then what do you think you can change? Okay, if they have no ideas, again, you can say, well, I've noticed these 3 things. Which one of these do you think would be easiest for your family to accomplish? And then, great, let's talk about that. And then you can give the information about, why, research has shown that 120 calories a day of juice leads to a 10-pound weight gain in a year. And again, how can we do this together? Okay, so you agree? You're gonna yes. Well, yeah. The honest truth is that's it's very difficult, we always ask about nutrition in virtually every child visit. So if you have a kid who's obese, you can leave aside some of the other things that you might cover. You can't cover everything every time, but this is a big health issue, and you have to spend a little more of your time, instead of talking about maybe sleep or talking about this particular thing. Yes.
I think over my years, I've been doing this for probably 20 years. I can count on probably 1 or 2 hands the number of very obese kids and the families of those kids who I've really gotten through to.
Yeah.
When I talk to these families and these kids, they become very defensive. They tell me all this kid drinks is water. They name all the fruits and vegetables he's eating.
Mm-hmm.
He never eats cookies or chips.
Yeah.
They name off like 6 activities that the kid's doing.
Yep.
And while he's sitting there, and his weight chart is looks like a statistic.
Well, if you have kids like that, you know that they're not being completely honest with you,
right.
Or else they don't know. Once a kid is in middle school,
right.
They lose some control.
They come back and see me.
Yeah.
I bring up weight, and they just want to totally shut off.
Yeah.
And I feel like I can't even talk about it anymore.
Yeah. Well, yeah. One of the things I would suggest is start talking about it before they're greatly obese, because that is it's almost too late then, and we'll talk a little bit about those massively obese kids later. But do you show them the growth chart? You show that. I find that that's a pretty powerful example, and I don't say obese usually. Say that they're in the unhealthy range. Anything over this line on the growth chart is in the unhealthy range, and my job is to help you stay healthy. Okay, it isn't about how you look. It's about your long-term health, and if you have if you can show them the 85th percent green line, whatever it is on your chart, anything above here, I have to worry because I'm worried about their health. And what can we do to help this? Yeah, people do get defensive. Sometimes, though, that if the kid's old enough, it depends on the age of the patient. But if you actually say, okay, let you get up at 6 in the morning, or well, tell me what time you get up and what's breakfast, and you go through, and this takes a long time, which is why it can't always be done at the physical. You might need another visit for that if you can get them to come back, and you can often find something that they tell you when they're going through the day, or they can come back with a food record for 3 days, and you can go over it with you. Dietitians often do this kind of work, and we're going to talk a little about using dietitians because they can be very helpful. But you can't fix everybody, but I think it's our responsibility to try to do the prevention as much as possible, and then you still have to bring it up because it's probably their biggest health problem right now. And it's going to lead to other things, but it can be pretty frustrating. So anyway, in the motivational interviewing, you try to set a specific goal, one little thing, okay, and then you ask them how important they think it is, and hopefully they think it's important because they helped to pick it, and then how confident are you that you can do it, okay? So if their confidence is low, you try to get at why. Well, why do you think you can't cut out juice? And well, they ask for it all the time, or and you have to deal with whatever that is, what their confidence is, or suggest that they pick something that they think they can do. It can be hard, but this is very often if you do one goal at a time, you can be more effective than if you're trying to change the whole lifestyle, because you know that nobody can do that. Anybody here ever tried to lose weight? Yeah, right. It's not easy, and you can't just change your whole life, or you can for a week, but it's not sustainable. So you want to, retrain the whole family to have better habits. Okay, so then you arrange for what happens next. So you're ready to make this change. Here's a handout that might be helpful, and we have a number of handouts that we give to patients. Is there anything else I can help you with? And then I want to see you back in 4 weeks. Okay, in 4 weeks, and you don't necessarily expect a kid to lose weight in 4 weeks. You want to have them come back, and hopefully they're the same. They haven't gone up another 2 pounds, and see whether they've been able to make that change. And if they have, try to take another little step, or find something else that might help. Okay. This is the AAP scheme of different assessment and treatment of obesity risk. And the first block is these are all this is the point. Is the normal range kids, and we see those kids, and we credit, oh, you're doing great, you're growing well. It sounds like you're. If there are any problem behaviors, you say, oh, if you ate a little more of this, a little of that, a little less of that, you might be healthier or get more iron or whatever. But mostly you're giving them positive feedback for their good choices. If they're overweight, you identify the problem behaviors and try to deal with it. And this, frankly, these 85th and 95th percentile kids are the kids I think we can have the most impact on in the office. Once they get over the 95th percentile, it gets really much harder, and that's why we have our obesity program. But it can be more effective we can have more impact on those medium kids. And once the kids are over 95th percentile, stage 1 is prevention plus, which is what we can do in the office. And the suggestion is that we give this 3 to 6 months of doing the kinds of things we just talked about with motivational interviewing, addressing sugar-sweetened beverages, addressing eating out of home, the things that we know are helpful in terms of weight control and maintenance. And so to try this for 3 to 6 months, see what kind of impact you can have. Kids who've been totally sedentary, if they're a middle schooler up, probably aren't going to be able to go out and run, do a lot of physical activity for a whole hour a day. So you might have to start a little smaller. But most elementary school kids are happy to go out and play for an hour. You just have to shut that screen. One of the other parts about this first prevention plus thing is you've got to involve the entire family. This is where grandparents or babysitter, nanny, whatever is very relevant. They may be part of the problem, very often are, and they have to also be on board with your plan, or it's not going to work, because they're probably with the kid several hours a day. Culturally appropriate counseling has to do with what people eat in their families, and also where they live in terms of physical activity. Some people live in neighborhoods where they can't just send their kid out and play, like in the suburbs. So they have to have more structured physical ways of getting physical activity. And again, regular PCP follow-up. Stage 2, after you do 3 to 6 months of that, the next level is to get more specific about food and more directive. And here's where a dietitian can be very helpful. Okay, you do more dietary counseling, and if you don't feel competent to do that, you can get help. Increase structure of the meals. Again, more handouts about portion size. Reducing screen time to even less. And increasing physical activity. The AAP recommends doing lab tests, screening labs for cholesterol and such if kids are 9 or over, and then refer to a dietitian and give yourself another 3 months and see how it goes. Okay. I want to say a few things specifically about screen time. There's many kinds of screen time now. Of all of them, TV still the worst. For a couple of reasons. One is the unhealthy food ads, because every kids show that has ads on it, most of them are about sugar-sweetened cereal, junk food, crackers, chips, and fast food. And they're definitely targeted at kids. 50% of the ad time is on foods, and you know what? They don't talk about healthy fruits and vegetables on kids' shows. They talk about Lucky Charms and Doritos, and it's a real problem with at least the phone and video games and such. Although that's screen time, they don't generally have the ads, and it's also. You can't eat while you're playing a game in the same way you can eat while you're watching television. So that's why I think television is the worst. And we all know that kids aren't supposed to have TVs in their rooms, but I bet most of you have patients who have TVs in their rooms, because I know I do. Even no matter what I say, they still do that. And can contribute to this whole issue. So the next stage is stage 3, or a multidisciplinary intervention for patients who, if you've done stage 1 and stage 2 and you're not making any progress, you can move on to a multidisciplinary team. And we have a program at the Floating called the Center for Youth Wellness. It's for teens only right now, although you're welcome to send younger kids, they just can't be in the group program. We do have a pediatrician and a social worker and a dietitian who work together with these kids. The program itself for the adolescents is a group program for the kids. They meet together. It's a 10-week program, 2 hours a week. An hour with the dietitian and an hour with some physical activity in the local Y. There's a program here in Lowell, actually. I think the one's running right now. And we see the kids one visit in the office, and then we have the program locally. this is more about the program. So there's a 1-hour visit in town where they meet the pediatrician and the social worker who do the assessment, because not all kids are appropriate for the group, though most are, but occasionally we get an autistic kid or someone who really couldn't be part of a group. And in fact, we're starting a group which will be only in Boston, but for kids who are autistic, a special group for kids with that kind of disability, which is very often associated with obesity. If you have children like that, we'd be happy to see them, but that would require coming to Boston every week for the 10 weeks, which is a kind of a big commitment. So it's it's 10 weeks. It's in a number of areas around Boston, so that patients don't have to go far. And there's a membership at the Y, which is free for the 3 months, and the meeting is at the Y. And each week they do a different physical activity with a trainer at the Y. They might play volleyball one week, play basketball one week, try the weight room, try the machines, so that they get to try different types of physical activity, which many of them have avoided, and maybe find something that they like or begin to feel a little more confident that they can do these things. And there's some follow-up visits that we encourage, but they're not required to be part of the program. We provide non-judgmental and enjoyable, affordable. It's only $50 per family they have to pay for the program. I have some literature about it in the back that Karen has. Our outcomes in terms of BMI are actually pretty good. Most obesity treatment programs, it's tough. Just like it is for all of you, it's hard for these group programs too. But many kids have reduced or stabilized their BMI, the majority of kids, during the time that they've been in the program. And we measure body fat as part of the assessment, and they've also decreased their body fat percentage because of increasing activity or for weight loss. We also, part of the program is to do pre-tests and post-tests, and we do know that the kids learn how to do better. Whether they do it or not is different. We all know what we should be doing, we don't all do it, but it provides a fair amount of education about healthy eating and activity, and we do some assessments of how many of these changes they've actually made. So a lot of them have decreased sugar-sweetened beverages, increased fruit and vegetable consumption, increased breakfast consumption, which now we're emphasizing a little less. The more recent data is that actually eating breakfast isn't that important in losing weight. It might help with doing better in school, but if kids who aren't really hungry in the morning, and that's a lot of your teenagers, they really don't want to eat at 7 o'clock before they go to school, it's okay. Give them a kind bar to take on the bus and eat in an hour. They'll be fine. There's no sense making them eat extra calories when they're not hungry. Other things, they've increased family meals. We do have one meeting with all the parents the first week to talk about how they can support their kid in this effort. And this is one of the things we emphasize with the families. And they've decreased screen time, and importantly, they at least say that they feel more comfortable with physical activity and trying new physical activity things. These are the kids who are the last ones to be picked for the team, right? So they're often uncomfortable with trying physical activity, and I think that's one of the real strengths of this program. The last stage of intervention is a tertiary care, a stage 4 intervention, which is basically surgery. It's a meal replacement, which is what most pre-surgical programs have, and consideration of surgery. It's a much more aggressive and intensive program. And it is done for adults. It's not actually approved in kids now, although we are working with our surgeons to develop a program starting at 15 or 16 where we'll start with the counseling and meal replacement part and do surgery at 18 if